internally rotate that leg with pronation, the patella cannot sit in its proper groove. It doesn't come up and down. You're this way now, and that's why you'll see with that elevated Q angle, you'll see patellofemoral syndrome with these kids all the time. If they overdo it and using proper shape, because instead of this patella moving this way, it rides up the lateral side, shears down the medial side. And the patella underside maybe has 5 cells of thickness. And guess what? You're riding up, shearing down. Riding up, shearing down. 10,000 steps a day, then increase it with running and all that other activity. You're gonna have pain. Then we try to do these McConnell tapes, strengthen these, strengthen this. But guess what? What are we doing? We're not getting, you think we're putting the patella in its groove? We're not doing that because the foot's still pronating and it can't possibly do anything but this. So you're actually perpetuating the injury. Look at the foot. If they're standing there, you're going to see it. You're going to laugh when you go Monday. You're going to laugh and you're going to go, you're standing there like this. And you're going, oh my God. Cohen said it. It was like, look at that. All I have to do is this. I've got to stop this. And I can do it with a generic insult. I don't need Cohen's cutting deal unless there's something special. You do like this, and standing there thinking like, he's killing me. Oh no. Not killing me. I don't know why. Where? We're right about in here. No kidding. And the best is you get to your doctor, and he never has him stand up. Go in like this. How you doing today? I'm fine. Where's the body? Oh, right here. Oh, okay. All right, see you later. You want to get this kid a script and get him over to PT. They don't stand him up. And God forbid, let him walk. You stand that kid up. So, I really think, not to belabor the point or make myself look very important or our profession look very important, that foot's pronating. I don't care what you're going to do. You're going to have to tell patellofemoral syndrome. Okay? Shame you can't see my video. It's pretty awesome. It's pretty cool. If you would see it, you would laugh. Of course, you know the traditional findings, the weak vastus medialis, the tight vastus lateralis. Here are the foot types. What's the most amazing thing about these foot types that I told you already? They are all excessive pronators. So that's all you have to know. And you have too much other stuff going on. You have 50, 60 kids coming in your room. All these are severe excessive pronators. Let me just explain that compensated transverse plane thing. That's excessive internal femoral or external femoral position, internal or external tibial position. Causes extrinsic pronation. So the foot may not be pronating as much, except it's externally pronating from another source, other than subpal joint or the metatarsal joint. Here's one of my biggest bugaboos, the medial tibial stress syndrome. Once again, I believe that it's tight gastroc, tight soleus is your primary guide for the deformity. The foot's always in equinus, so when the foot's in equinus, the foot cannot adequately dorsiflex on the ankle. Okay? You need 10 to 15 degrees of dorsiflexion with the foot in the neutral position and knee extended. That's come under some fire lately because it hasn't changed that long. People think, well, wait, in motion it maybe should should be higher with weight bearing, but it's all through non-weight bearing, all the literatures are non. But it's still, you got to remember, the leg rotates over the talus 10 degrees to get you to the next step. If you're robbed by that of equinus, then the foot breaks down in the middle, either the mid-tarsal joint, subtalar joint, which creates motion, which acts as pronation, and then becomes excessive pronation, and you get a breakdown in all the joints. So the equinus is the hugest problem we have. We all wear heels, guys, whatever. It's a congenital shortness. Every running activity, as you know, tightens the posterior muscle groups, and no one's working on the anterior muscle groups. So, what do I do?
Can I ask a question?
Yes.
What about cross-country running? The type of shoes that they wear. I don't know what the literature says on this, or whether there's been enough on it. They run on rigid crossing and rigid sole shoes, therefore it shortens their Achilles, which may predispose them to shin splints. And I've heard some schools have thought the off-season they should run on the sand to create a little bit more flexibility so that they elongate their Achilles so they won't have shin. What's your take on that?
Okay, there's two things there. There's the Achilles, which is a question about posterior muscle group, which is medial tibial stress syndrome, because that's what I'm talking about. So, number one, I think you have to make sure with the barefoot running, I think, and there's been a big resurgence in this, I think there's more harm with it than good, because there's always like stupid stuff, like where are you going to run this barefoot run? And what are you going to step on? And are you going to step in a hole and step into the stand? And the heel actually goes down too far in a barefoot run. I think you're better off to prevent that. You want to do intrinsic foot muscle exercise. That's the important thing about it. We don't exercise the intrinsic muscles enough because we're in hard surfaces and real protective shoes. So I think if you want to do that barefoot thing, I think you're better off doing intrinsic muscle exercises, the camel toes, the marble pulls, toe raises, heel raises, that sort of thing. Keeping in mind that I believe that dynamic stretching is the way to go instead of just doing this, doing this. I think there's some dynamic stretching that you got to do. I'm just not a barefoot running advocate. I'm an advocate of exercising the intrinsic muscles to keep everything in balance. You got to balance the front to the back.
Dr. Cohen, what do you know about the five-finger shoes?
The five-finger shoes are the same. This is what's going on with the barefoot running.
So it's more similar to barefoot
It's
running?
absolutely barefoot. It is barefoot running, except it has the protection of the sole, so you don't get to step on something. My problem is, 80% of the people that I see have some type of mechanical defect. So for the 15% of normal foot types, go ahead, knock yourself out. But I really see a lot of pathology. Maybe that's why they're there. But for those people, so I'm not putting it down. I'm just saying, if you do it, you feel you have a normal foot type, you have a normal exam, good flexibility, and normal forefoot to rear foot, it's a great part of the incorporation because it changes you up and gives you some more muscle strength. So I think it's great. If you have some pathology, you're going to get into trouble. We got into trouble when we recommended all the Nike Frees in the beginning. When they came out and we ended up with lows. That's plantar fasciitis, heel pain. So you got to pick your poison. So normal foot, you can do anything probably with normal training.
Doesn't pose work with barefoot running to correct all mechanical?
It works with that real baby thin sole shoe. Most of the track coaches, they'll say, no, I'm the coach. This is what we do. And I don't blame them. They're trained. That's their deal.